Welcome to the webinar of a recorded demo of the ultrasound examination with Daniel Shelton and Bill Medford. Daniel Shelton is the Director of MSK Market Development with over 16 years of experience as an MSK sonographer. Bill Medford is the lead MSK specialist with over 40 years of experience as a sonographer and 22 years of that experience in MSK. This slide shows an outline of what we will cover today, and Bill will begin with a review of the role of ultrasound in elbow examinations.
To begin, let's discuss the role of ultrasound and where ultrasound commonly contributes in assessing the elbow. Transducers that we will employ during this time will include higher frequency transducers such as the linear array 19 megahertz and the linear array 15 megahertz transducers in the MSK or the nerve preset. Ultrasound can be of help in assessing chronic or acute conditions or injuries to muscle, tendons, or ligaments, and certainly assist in evaluating bursopathies, as well as nerve entrapments and pre-entrapment swelling of nerves. We can certainly recognize joint effusion when present. We can assess trauma and resulting hematoma, identification and location of masses, soft tissue masses or cystic masses, and classification as to whether they're solid, whether they're cystic, or whether they're mixed solid and cystic component. We can assess post-surgical complications, in particular infection and abscess formation. We can guide injections, as well as direct the needle for aspiration. Bony pathologies such as extra-articular arthritic change we can see, as well as occasional appearances of fractures, and often overlooking them as being important, but highly important is just simply to be able to confirm the normal appearance of structures. We're going to break the discussion into anterior, lateral, medial, and posterior segments accompanied by Daniel's live demo. So let's begin with the anterior elbow, where we'll discuss the radial humeral joint, the ulnar humeral joint, as well as the biceps brachii tendon. As with all MSK applications, recognition of skeletal contours is important as landmarks for the soft tissue anatomy we're assessing. Beginning with the transducer placed in the longitudinal plane to the extended arm on the lateral aspect, we will first identify the characteristic bony contours of the radial head and the rounded humeral capitellum. Those two landmarks in view, we now see two locations where effusion might be seen: the annular recess just distal to the radial head, and the radial fossa just superior to the capitellum. The brachioradialis muscle is seen anteriorly here. In these two images, we see the normal appearance of the anterior radial side of the elbow on the left, while on the right, we can see anechoic effusion distending the joint recess over the capitellum, extending superiorly to the radial fossa. Sliding the transducer medially, still in a longitudinal scan plane to the arm, notice that opposed to the squared off appearance of the radial head, we see a more pointed appearance to the coronoid process of the ulna. Superior to the ulna is the humeral trochlea, and moving just superior to the trochlea, we recognize the coronoid fossa, so named as it will, when the arm is flexed, accommodate the position of the coronoid process. So now let's turn the transducer transverse to the antecubital fossa. As we position the arm just superior to the humeral trochlea, the examiner will demonstrate the radial and coronoid fossa in short axis. Note the absence of articular cartilage here. Sliding the transducer slightly more distal, The articular line humeral trochlea will become more apparent. On the next two slides, we'll look at the anterior lateral and anterior medial structures. As we see here, on the anterior and lateral side, over the humeral capitellum, we can identify a brightly echoic fascial plane interposed between the brachioradialis and brachialis muscles. Within this fascial plane are the superficial and deep branches of the radial nerve. On the anterior medial side, over the humeral trochlea, we want to identify the brachial artery. Immediately lateral to the brachial artery is the most superficial portion of the biceps tendon. Medial to the brachial artery and interposed in the hyperechoic fascial plane between the pronator muscle mass and the brachialis muscle, we will see the median nerve. Pronator muscle, brachialis, median nerve, brachial artery, and biceps tendon. With the arm extended and in hypersupination, we begin examination of the biceps brachii tendon in the short axis. We begin at the myotendinous junction, which is slightly proximal to the level of the humeral trochlea, and this is the level where it is most superficial and easy to palpate. A useful anatomic landmark is the pulsatile brachial artery. Lateral to this is the bicep tendon, and medial is the median nerve. We can use anisotropy to help locate the bicep tendon by wagging the tail of the transducer back and forth and recognize the alternating appearance between hyper and hypoechogenicity. With the probe moved more distal over the radial neck, the bicep tendon is deeper as it courses toward its insertion on the radial tuberosity. Moving slightly more distal, visualization of the insertion of the biceps is aided by forearm supination, which will rotate the radial tuberosity to a more anterior location, bringing with it the fibers as they insert onto the radial tuberosity. Bicep tendon, branch of the brachial artery, median nerve, pronator muscle. Long axis imaging of the distal biceps tendon requires attention to transducer technique as well as patient arm position. The arm will remain extended. The transducer is placed in a sagittal plane to the arm to visualize the proximal portion of the biceps. As the transducer is moved more distal, the forearm will be placed in hypersupination, and the scan plane will change from sagittal to oblique. The distal end of the transducer is more medial, while the proximal end of the transducer is more lateral. With that scan plane obliquity, tilting the probe now from medial back to lateral and applying a heel-toe probe maneuver will result in excellent visualization. Daniel, I'm going to turn it over to you to demonstrate these components of the anterior elbow exam.
Well, thank you, Bill. Today we're going to be using the newly released Sonosite PX. I'll be using the L15-4 linear array transducer to examine the anterior elbow. Later on more superficial structures like the lateral and medial side, we'll be using a 19 megahertz transducer, which provides excellent visualization. So as Bill said, I'm going to start right here in the front part cross-sectionally. I'm going to bring the orientation marker over here to the patient's right. So screen left will be the patient's right. I've got an arrow up on the screen, and I just want to start with the obvious cortical landmark of the distal humerus here deep in the image. And as I start to see the Actually, let's start long axis like the PowerPoint. I like starting that way anyways. It's more of a classic, I call this kind of a dog bone appearance. If you're showing a patient or something, somebody that's learning ultrasound for the first time, especially musculoskeletal, what we're looking at here on the screen, this is an easy window to see things like bone, okay, bony surfaces, a joint come together, and pretty obvious muscle striations. So this is a great window just to start an elbow exam for anybody that's learning. Distally, we do have the radius, the radial neck, head, distal humeral capitellum here. Proximal to that, we have the radial fossa and the annular recess here distally. So we're not seeing any joint effusion here or here in either of these fossa. We're looking at the cartilage to make sure that it's nice and uniform. There's no thinning, there's no erosions, there's no divots, no floating calcium. Everything looks pretty good here. So at that point, what I do is just take some of that gel over to the medial side and just aim over towards the ulna. So the ulna is more sharp and pointed. I'm aiming the beam much more medially, as you can see on the screen there. Distal to that, I'm looking right here in the coronoid region for more effusion to dump out, and then proximally I'm looking in the coronoid fossa here, and I don't see any effusion to worry about here. Here's that nice fat pad that we're looking at here. So if I don't see a joint effusion, I'm also evaluating that cartilage surface again and wanting to pan across the joint for any underlying joint effusion that might be spilling out proximally where they tend to rest. So I'm going to now switch over to cross section here, and I like to start on the proximal humerus. So, it's not the proximal humerus, the distal humerus proximal to the elbow joint. So here I can see the beginning of the fat pad. Here I'm radial, and I see cartilage. So if I wanted to be in the radial fossa, I just need to be proximal to the cartilage. So here's the fat pad of the radial fossa here, and then more medially over the coronoid fossa here. Now I'm over the distal humeral capitellum area, and I'm looking at that cartilage in cross section, really nice. Kind of like looking at a distal knee, like the sunrise view. We look at that entire cartilage surface here, and as Bill mentioned in the PowerPoint, we can really see nicely that radial nerve with its superficial and deep branches. We could follow that out a little bit more distally and watch it kick out another branch into the its posterior interosseous branch here, going into the arcata frouxe, for example. I'm going to go right back up approximately to the cartilage level, and I've already evaluated for the effusion here. And again, checking medially right over that fat pad here. Now to the cross-sectional superficial structure, which I think needs the most attention in the anterior elbow. Most people are most curious about this distal biceps tendon exam, so we're going to focus a lot of time on that today. If you're fairly new at this and you're just getting your bearings as to where we are on the screen, the distal biceps tendon is really nice to scan because you can feel it. With just even slight flexion, it doesn't matter, but I can feel the distal biceps tendon here. Place that in the middle of the screen and you see where my arrow is. Now, medial to that, the other surrounding landmarks we had was the brachial artery, okay, and then we had the median nerve. So they will border each other here momentarily as we go distally, but we're going to look at this very superficial tendon right here. We're going to use anisotropic artifact to our advantage as we trace it distally to the radius. So already, you notice I've not angled the transducer one bit, and as I go distally, that biceps tendon has started to dive. And when it dives, it really gives itself away with the anisotropic artifact, or the angle artifact. So here we're going to follow that shadow, and follow this shadow, still distally, still following this shadow. If you want to make sure it's not a fluid collection, we're just going to aim the handle distally and cut that tendon at 90 degrees. So let's do that right here. So follow this shadow and make sure it all turns bright. There you go. Very nice. And I'm going to follow the shadow again because anisotropic artifact is not always bad. Now watch that anisotropic artifact start to merge with the radial neck area, and then after the radial neck, as we saw on the long axis, we'll see the radial tuberosity. So here that anisotropic artifact is starting to splay out and follow the radial tuberosities and thesis right here. I'm going to check my angle and angle the handle distally. There we go. And look for maximum reflection. If you're not confident you're seeing all these fibers, as Bill mentioned in the PowerPoint, I'm gonna supinate, bringing that radial tuberosity much more anterior. So here we are with the distal biceps tendon very anterior now. I can get a very nice 90-degree cross section on it, where it's most important to see the breadth of the tendon and all of its fibers. From here, if you wanted to go long axis, you could. It's kind of hard to pivot on because the antecubital area here of the elbow tend to be very, very hard to traverse with a linear array transducer. So if I wanted to go long axis on that, I might get lucky and get the radial tuberosity in long axis. But I would just coach you to start right back over that dog bone that we started with. So here we kind of see the distal humerus and the radial fossa again. Distal radiocapitellar joint, okay, radial head and neck. And if you look at the anatomy diagrams, we don't see the radial tuberosity anywhere over here. It's after the neck. So after the neck, I'm looking for the distal biceps tendon here, and I know that it's pointing more medially, more medially towards the ulna almost. With hypersupination, I'm going to traverse this way medially and aim laterally. Because we're scanning a cylinder, I have to aim back into the cylinder to hit that distal biceps tendon properly. So what I'm going to do now is go medially and aim the beam back into the cylinder. And there we have that radial head, neck, and tuberosity showing itself really nicely. And if you don't see the proximal aspect of the image looking nice, just pivot the proximal part of the probe right over where you palpated. And we're just going to fan it. So we're going to plant that distal part of the probe and just use this like a windshield wiper across until we see that really nice distal biceps tendon right there. So here we are on the long axis, the anterior window of the distal biceps. If we make it through everything with plenty of Q&A time, there are other windows to evaluate the distal biceps tendon not covered in the PowerPoint, and we can show those in the live demo. But I think I'm going to go ahead and turn it back over to Bill, unless I miss anything. Bill, should I cover anything else?
So moving to the lateral elbow, we're going to direct our attention to the common extensor tendon, as well as the lateral collateral ligament complex. When evaluating the tendon ligament anatomy of the lateral elbow, we want to present the bony contours of the lateral epicondyle and the radial head. Coursing over the radial head, we'll see the common extensor tendon as it approaches its synthesis on the lateral epicondyle. With the elbow bent at 45 to 90 degrees, the transducer is lined up with the forearm. In the scan plane, we'll look for a sharp ski jump shape for the lateral epicondyle, as well as the squared off contour of the radial head. Now, cadaver studies have shown that the superficial 2/3 of the downslope of the lateral epicondyle accommodates the insertion of the common extensor tendon, while the deepest third of that downslope receives the fibers of the radial collateral ligament. So if we look at this sonographic image here, we see the difference in echogenicity between the slightly more hypoechoic radial collateral ligament and the fibrillar pattern and slightly more hyperechoic appearance of the overlying common extensor tendon and the radio-ulnar or radiohumeral joint here. This distinction becomes important when we're guiding regenerative tissue injections and we have isolated the injury as to either the radial collateral ligament or the common extensor tendon. With these two images, we have a couple of enthesiopathic findings on the lateral epicondyle. You have a tiny little calcific focus that we see with 15 megahertz frequency employed. And we also see this zone of hypoechogenicity here. So we can recognize the pathology nicely, but look what happens when we employ higher frequency, 19 megahertz. Look how much more clearly defined that focus of calcium is. And so now we can better determine whether or not this is spurious off the bone or whether it is isolated calcium to the tendon. As well, we can see what is a zone of hypoechogenicity here with 15 megahertz, but with 19 megahertz, now we can see that there's a fluid component to this zone of hypoechogenicity, and we can see the brightly echoic back margin, which you frequently get with fluid. So this gives us more information and gives us more confidence in characterizing the nature and also the location of the pathology present. The lateral collateral ligament construct is made up of the radial collateral ligament, the annular ligament, and the lateral ulnar collateral ligament, sometimes called the Lateral. The LCL inserts on the lateral epicondyle proximally and interdigitates with the annular ligament. The annular ligament courses from the posterior to the anterior margins of the radial notch on the ulna and circles the head of the radius and holds it against the radial notch, providing radio-ulnar stability. The lateral ulnar collateral ligament, or LUCL, also originates from the lateral epicondyle, from where it is indistinguishable from the radial collateral ligament, and courses to its distal insertion on the supinator crest of the ulna. Daniel, I'll turn it over to you now for demonstration of the lateral elbow.
All right, thanks, Bill. I'm going to start the exam with the standard L15 transducer, and we'll look at the difference between the 15 and the 19 when looking at the lateral epicondyle. So typically, depending on how you're seated, I will scan with a finger underneath the transducer surface. In this case, I could use my thumb. I could get away with that. But for the camera angle's sake, I've got everything turned around. So I like to scan with something hanging under the probe, especially when I'm scanning things like epicondyles, because what it does is it provides kind of a backdrop for the epicondyle to stop, and then you just have to worry about pointing the rest of the transducer, in this case, towards the dorsal wrist, where these common extensor tendons are all tapering off to. So just to understand the trajectory, I would just palpate that lateral epicondyle left side of the screen and then lay the rest of the transducer down and just pivot like a windshield wiper like we talked about earlier until I was pointed towards the dorsal wrist to elongate that common extensor tendon. I'm going to bring our depth up just a little shallow here. I'm going to change my hand position for the camera, and then I'll start pointing out the lateral epicondyle surface anatomy here. So superficially, we have the most superficial aspect of this first 2/3 that represents the common extensor origin here, as Bill mentioned, and then the lower 2/3 or the lower third really mentioning the radial collateral ligament insertion. Here, if I angle the probe correctly, we'll catch a little distinction. It's kind of hard on a normal elbow to see the difference between the radial collateral as it tapers from the annular ligament complex here underneath the common extensor tendon. So here's the common extensor tendon right here up top, this long axis, very elongated structure that we can see going into the forearm. Underneath it, something that looks a little less long axis right here on top of the radial head, and we can have our patient pronate and supinate, just palm up, palm down, and see the annular ligament in action. So that's what's really kind of fun about ultrasound, is just watch these fibers twist and turn. Right there we see the radial collateral ligament become pulled by the annular complex when she goes into hypersupination. Right there, really nicely. So that's another really nice advantage of ultrasound. Put this anatomy into motion anytime you can. Anytime you're scanning with ultrasound, you should always make the anatomy move, or this imaging modality is no better than a basic MRI. And we all know those are very boring. I'm going to switch over to the L19. Sorry for anybody that loves their MRIs. We're kind of biased. Not saying this completely takes the place of an MRI, but it does a pretty good job. So on the left side of the screen, actually when we switch to the L19 from a perspective standpoint, it starts at a much deeper depth than is necessary. That's because at 19 megahertz, things are very much blown up on the screen. I'm just going to bring our depth up more shallow here. That way we can kind of take advantage of the full screen effect here. Get my arrow back up there. So here's our lateral epicondyle, that first 2/3 being the common extensor tendon, and then that lower 1/3. And actually, I can see that anisotropic artifact just making itself a little bit more known right here in that almost neck of the epicondyle, if that's such a thing. I'm going to follow this ligament up over to the annular again. And what I like about this transducer is I'm able to see this edge artifact representing the distalmost portion of the annular ligament complex. So I like to know kind of where to stop looking for things. And let's go ahead and do the pronation and supination again, and we'll just try to follow that radial head for any defects in the cartilage. I'm looking for anything in that ligament complex to snap or drag or click or pop. Again, taking full advantage of the dynamic nature of ultrasound. I'm going to go short axis to this cartilage. It's just a very nice view to do. So there I've rotated the transducer on 90 degrees here to the radial head. Radial head has the cartilage right here. Lateral epicondyle does not. So I jumped over the joint now. I'm moving proximally, and we're over the lateral epicondyle surface. So this is the more ulnar side of the lateral epicondyle. It has its own little protruding bony facet like we saw on the shoulder. And we're going to look at the groups of common extensor tendons attaching on the ulnar side and the radial side. And then I'm going to just scan and pick one of these and scan distally, and then come back proximally and pick another one and scan distally, and then pick another one and scan distally, and so on and so forth. Because it's a fanning common extensor complex, basically you have to kind of pick a bundle and fan the beam down the extremity until they taper out to their musculotendinous junctions. But it's a really nice thing to be able to observe and watch this annular ligament in motion right here, this horizontal band on the screen. I'm going to go ahead and have Jamie, our model, pronate and supinate again, and let's watch the origins of this this annular ligament complex attaching or originating here on the proximal most aspect of that supinator process, I guess, of the ulna. But you can see that ligament very nicely here, kind of shrouding that radial head. So more dynamic exams. We're looking for more popping, clicking, snapping, any injury to this ligament that might have occurred from a fall, for example. This is a great thing when people kind of fall and internally rotate as they're trying to catch themselves, to come back here and check this ligament and its stability. Bill, did I miss anything on this outside part, the lateral aspect of the elbow?
Nope, I think you did a great job.
All right, I'll send it back to you, Bill.
Let's now move on to the medial aspect of the elbow, where the primary anatomy of interest includes the common flexor tendon as well as the ulnar collateral ligament. Using a similar starting point as was used on the lateral elbow, our palpation landmark will be the medial epicondyle, and this will serve as a physical transducer pivot point, as well as a sonographic bony acoustic landmark to demonstrate both the common flexor tendon as well as the ulnar collateral ligament. The transducer will again line up with the forearm to produce a long axis image of the common flexor tendon. Of note is the very short length of the tendon-only portion of the common flexor tendon. Notice here as it inserts onto the medial epicondyle that once it departs its enthesis, it immediately becomes myotendinous. The very superficial nature of the common flexor tendon enthesis also lends itself well to interrogation with a higher frequency small footprint transducer, such as the 19 megahertz linear array transducer shown here to the right. With this, we're going to see finer detail, we're going to recognize improved image clarity, and likely see more subtle echoarchitecture changes. While the wider footprint L15 transducer, while it provides exceptional image clarity as well, is going to provide us a wider field of view while maintaining exquisite image quality. To present the ulnar collateral ligament from the transducer position for the common flexor tendon, we're going to sweep or fan the distal end of the transducer until the sublime tubercle of the ulna is seen. This bony acoustic landmark is the distal enthesis for the ulnar collateral ligament. Note that we are seeing the anterior band, which is most commonly injured and repaired via Tommy John surgery. The ligament is seen to broaden proximally and substantially narrow at its distal insertion on the sublime tubercle. The medial elbow anatomy is often accessible to higher frequency sound as well, as we see here. While the linear 15 megahertz transducer provides very impressive image clarity, the 19 megahertz takes this detail to another level of image clarity. Note the margin definition of the mid to distal ulnar collateral ligament and the exquisite detail at distal enthesis. Note also how well differentiated the deep peritendinous fatty tissue is from the far field margin of the ulnar collateral ligament. Although with 15 megahertz, a small bit of fluid in the medial joint recess can be seen here. Imaged with the 19 megahertz, this tiny amount of fluid becomes more apparent and is seen with greater clarity and confidence. So 19 megahertz frequency can certainly be a game changer when you're looking at fine detailed anatomy and you're trying to develop an increased level of confidence in what you're seeing. The dynamic maneuver of real-time observation during valgus stress can also be very helpful. This can be accomplished a couple of different ways. The way I like to do it is, and is demonstrated on this slide, is have the patient supine and rest their elbow over the edge of the table, which provides a fulcrum. And then with gentle pressure down on the forearm while observing the joint space can help recognize degrees of joint laxity. Okay, Daniel, I'll turn it over to you.
We are starting with the L15 transducer, and for the camera's sake, just getting the cord out of view, I like to use my finger hanging down again to palpate the medial epicondyle for this common flexor tendon origin. So what you're probably not seeing kind of behind the scenes here is how my finger is hanging down. So it's hanging down here and it's providing a pivot. And I start right there on the common flexor origin on the medial epicondyle. Let's pull the arrow back up here. So let's see. There we go. There it is. So here, medial epicondyle, and we're looking at these fibers all across that footprint, just like we did on the lateral elbow. And you'll notice that the fibers stop a little bit more short. That's because the muscular tendinous junction of the medial elbow is much shorter. The muscle is larger in the forearm, and therefore the tendon attachment is a little bit shorter than the common extensor complex. So fanning across here, looking for subtle abnormalities here. I'm not seeing any here, but that may change when we switch over to the 19. And then while I have this transducer here, what I'm going to do is just kind of show you that pivot that takes place to see the UCL. So we're going to go from, my fingers are still underneath the medial epicondyle right here. They're just butted up right here. Medial epicondyle is right there where my finger is. And I'm just going to plant that right there. And then all I'm going to do, now that I have the medial epicondyle up here in the upper screen left, I'm just going to fan the distal part of the transducer until I elongate this ulna. You can see how the ulna, the sublime tubercle, is kind of diving down. I'm not seeing the UCL yet. I'm still relatively over the flexor tendon mass, really. But watch the ulna elongate. I'm just going to drop this part of the transducer, the distal part of the transducer, until it elongates with the ulna here. So once you've elongated with the ulna, and it also helps to flex the elbow. There we go. That's how you get the proper view. I forgot to mention flexing the elbow. So I'm just going to reposition here, so hopefully my hand is not covering everything. So here we are, left side of the screen, medial epicondyle, right side of the screen, sublime tubercle of the ulna. And we see it very nice, and I can see the ulna is elongated. And what I'm looking at is this kind of bugle-shaped ligament complex. As Bill mentioned, it tapers off pretty large proximally here, right across this entire footprint here. And we can see that really nice band coming together here as it jumps over the humeral ulnar joint to the ulna here, the sublime tubercle of the ulna. So this is the UCL in a long axis with the L15. And we'll switch over for comparison to the L19 just to look at those differences in how we can see the enthesis much nicer. Little NASCAR pit stop here, changing over. Now we're going to see something that looks almost like a tendon. It's so big when we look at things with the L19. I'm going to bring our depth up more shallow, bring the arrow back up. And here I can see these fibers with a lot more confidence, as Bill said. Even with the 15 megahertz probe, which was beautiful, I'm actually seeing fibers that we don't normally get to count. We see the shape of the UCL typically. We rely on anisotropic artifact because the fibers are so dense, but we don't typically get to almost count these ligament fibers that we're seeing inside here. And then here I am right at that enthesis to the sublime tubercle of the ulna. Looks really, really nice. And I'm sure if I were to toggle my transducer just a little bit more and catch those fibers a little bit more level, we would see a lot more detail. Now, when you're doing a dynamic exam, the way I'm sitting right here with the camera, I was noticing kind of in our warm-ups, we don't want to arm wrestle the patient too much and put too much stress and tilt on the patient. So let's watch this joint and watch what my shoulder's doing up here in the bottom of your screen. I'm just going to bump shoulders here with our model and act like a rest. And then since her elbow is bent at least 30 degrees to disengage the olecranon process from the fossa, I'm just going to go ahead and do that arm wrestling maneuver, okay? And I'm not really looking at her facial expressions here. I'm waiting on her to get mad or something, or maybe hit me, but I'm guessing it's not hurting. So this typically won't hurt unless there's a lot of damage there, no matter how much of an arm wrestle you provide. But no gapping in the joint to speak of, a little movement, and that's okay. But as long as we don't see that thing open 2 or 3 millimeters on a non-athlete, I think we're in good shape. Bill, did I miss anything there? We good?
Okay, with that, let's move on to the posterior elbow. Here we'll review the triceps tendon, the olecranon fossa, and we're going to look at the cubital tunnel, which houses the ulnar nerve. To examine the triceps tendon, the elbow is flexed to achieve lengthening and tension. The olecranon provides a palpation and bony acoustic image landmark for the distal end of the transducer. And much like the quadriceps tendon in the knee, the fibers of the 3 muscles of the triceps tendon converge to a single tendon to insert on the olecranon. Observation during flexion and extension of the elbow can be very helpful in evaluating the triceps for tear, and can also assist in identification of loose bodies that can be pushed out into the olecranon fossa. So the olecranon fossa here, humeral trochlea, humeral ulnar joint. So some folks will actually guide needle right to this location here with the elbow flexed. Or conversely, and we'll show you in the short axis here in a second, it can be directed deep to the fat pad in the olecranon fossa. In evaluating the olecranon fossa, we also want to turn the transducer 90 degrees to look across in the axial or short axis plane. With this view, we can also recognize a fusion where this fat pad that we see here will be elevated. Can recognize loose bodies and also guide an in-plane injection across, well, as we're looking with the transducer placed across the elbow, to place the needle along the articular cartilage here, where we know that if needle tips sitting against the articular cartilage that were placed in the knee joint and delivering our injectate where we want it delivered. In this long axis image, fluid distension of the posterior olecranon bursa is seen, very superficial. And as such, and as a reminder, much like the prepatellar bursa, a bit of transducer pressure can collapse a fluid distended olecranon bursa. So gentle transducer pressure or floating the transducer in a heap of conducting gel can avoid this pitfall. You have to be very mindful when we're scanning this very tiny superficial that we can obliterate the appearance of this fluid with too much transducer pressure. So personally, I prefer if I have a reddened elbow and I'm suspicious of what might be filling or distending the bursa, the olecranon bursa, I'll use a gel heap and float the transducer. Moving on to the cubital tunnel, where our bony acoustic landmarks are the medial epicondyle, the humeral ulnar joint, and the olecranon. The patient arm is flexed 90 degrees, and the transducer is positioned so as to bridge the cubital tunnel by placing one end on the medial epicondyle and the other end on the olecranon. The ulnar nerve will be seen along the surface of the medial epicondyle. Real-time dynamic assessment of the cubital tunnel during flexion extension can demonstrate subluxation of the ulnar nerve. As we look at this video and we see the ulnar nerve here as it snaps across the medial epicondyle. Here it comes right there. Applying very gentle transducer pressure, floating the transducer in a gel heap is essential, as well as too much pressure can actually prevent an otherwise subluxing ulnar nerve from jumping across the medial epicondyle. On the series of images below, we're using a 19 megahertz small footprint transducer, and we can see Osborne's ligament, which houses the ulnar nerve and intact prevents it from subluxation. Here we see from left to right the ligament in varying degrees of stress. So with the arm flexed at 90 degrees, we see a pretty relaxed ligament and the underlying ulnar nerve. With advancing degrees of flexion, now we see invasion of the cubital tunnel by the anconeus trochlearis muscle, epitrochlearis muscle, if present, as well as the medial head of the triceps. And this can certainly reduce the space to which the ulnar nerve resides and push it up along the undersurface of Osborne's ligament. And we notice here how the ligament now is becoming straighter as the nerve pushes up on the underside. And with even full flexion, now we see the median nerve, even less space for it, pushing up and actually bowing this ligament. As we would with the median nerve as it enters the carpal tunnel, we also want to evaluate the ulnar nerve and long axis through the cubital tunnel as it enters the flexor tunnel, which is a potential zone of entrapment. The transducer is turned 90 degrees from the short axis plane, snuggled into the cubital tunnel, then rocked in that same plane back toward the medial epicondyle while we look longitudinally for the longitudinally oriented fascicle pattern that's characteristic of all nerves. And once the nerve is longitudinally aligned, pre-entrapment swelling may be observed when present. Daniel, I'll let you take it now and take a look at the posterior shoulder for us.
And I'm going to kick it off with the L15 right across the posterior olecranon surface again, palpating again depending on your position. I like to just keep a thumb or something here. That way when we're doing those extension and flexion maneuvers, your transducer is not too far rocked off of the area of anatomy that you're looking at. So you'll see me hang a pinky down in this case and just lean the transducer right up and over the humerus, and hopefully on the screen looks really good. Superficially, going horizontally, you can see that triceps tendon as it starts to fan out to its musculotendinous junction. This is another great area just to show a patient, hey, this is why we're doing ultrasound. We can see fluid collections, loose bodies, pretty common area to see loose bodies entrapped down here. And when we do that flexion extension exam, watching them move around or not move around, which can also add to the diagnostic information of the exam. So the joint capsule, you can see beautifully here. We're visualizing what looks like a cartilage interface sign if we were scanning the shoulder looking for a cuff tear, for example. This is just what happens when fluid from a joint rests on top of the shiny surface of cartilage. This is the articular hyaline cartilage on the posterior humeral trochlea in the olecranon fossa's beginnings here. So that really nicely shows where the joint fluid is coming out and over the cartilage. It does trickle under the fat pad. It's dry right now, but this is where you'll see a large joint effusion if you have one. With the resolution of this L15 transducer, we're really seeing nicely with very little to any artifact the very hypervascular nature of the posterior triceps right here as it starts to go through the fat pad. So if you are going to drive a needle through here, as I've seen many people do blind or on fluoro, and you're going to drive a needle straight under the fat pad and just jam it into the olecranon fossa, hoping to hit the joint, try to avoid these little bleeders here like we see that could leak into the joint. So we want, as much as possible, not to cause a bleed in a joint, because red blood cells, as we know, are very toxic to joints, and you might even cause an unwanted hematoma. So always throw the color on, especially on these very hypervascular fat pads. They are much more vascular than you might think. So what I'm going to have our model Jamie do as I rest my arm back here is just to have her slowly extend and flex, and we're going to look at that area for any loose bodies. So go ahead and flex again. Good. And extend. Good. And flex. And just about half speed. There you go. And then flex again. And I don't see any loose bodies or anything like that, so I'm going to have her just relax. And then I'm going to go short axis just to show that I don't have any joint effusion. So back over the triceps and the olecranon fossa here. So triceps, olecranon process. Proximally here we hit the cartilage that we saw the fat pad start to originate on. So more towards the medial epicondyle and more towards the lateral elbow here. But this is kind of a classic landmark. This is that groove that the olecranon process follows. And you might even just catch a sliver of the distal tip or proximal margin of the olecranon process right here. There it is. So this is the olecranon process right here. As it, you can see it kind of cupping in to that fossa's same shape. And then we come down here and examine the fat pad. And cross-sectionally across this fat pad, we see a lot more anatomy than we did in the long axis. That's why it's really important to do these things in two planes. So I don't notice any loose bodies. There's no debris. I don't see any effusion. I don't see any hemarthrosis. These are all things that we want to look for in this view here. Going more distal now, let's look at the enthesis of the triceps tendon superficially, checking out its integrity. While I'm in this area, I'll typically just slide the transducer medially, and I can feel with my fingers the medial epicondyle here. So what I'm going to do is use that as a pivot, and you can see my finger just hanging underneath the transducer right here, and it's just going to act as a pivot point and kind of a pressure stabilizer so that I'm not applying too much pressure on the medial epicondyle while I do this ulnar nerve exam. So my finger first goes over the medial epicondyle, and there we can see on the left side of the screen the medial epicondyle's bony margin here. Here's the ulnar nerve with the 15 megahertz transducer, and we're going to make it look really nice with the L19 next. So very hypoechoic honeycomb appearance here. You can see all the little fascicles inside. Looking at that transversely oriented Osborne's ligament that just sits right up on top of the ulnar nerve here. This transducer may make it a little tough to do the dynamic flexion, so I'm just going to raise Jamie's elbow up, and she's just going to go into flexion for me. Other way. There we go. Good. And extension. Watch it slide back down low. But with this large footprint, go ahead and flex again. It can be a little bit cumbersome to manage for these smaller nerve exams. So what I'm going to do is just have her relax. We'll switch over to the very nice L19 transducer. Okay. Same thing. I'm going to use my finger as a pivot point again. So right here, this bottom part of my finger is just going to rest on the medial epicondyle. And then we're going to see the ulnar nerve tucked nicely against the side wall of the medial epicondyle. We're going to see a lot more fascicles in there than we've probably ever seen. Maybe not ever. There's more research-driven machines with higher frequencies, but I tell you, every time I image with this transducer, Bill, it starts to remind me more and more of those kind of research-level images when we're looking at all the tiny fascicles in the nerve. So one tip is distal to the medial epicondyle. I'm going to take my transducer and do kind of an about face right down the two heads of the flexor carpi ulnaris. So we have one head of the flexor carpi ulnaris inserting on the olecranon, and then the other head of the flexor carpi ulnaris inserting on the medial epicondyle. The ulnar nerve leaves the osteofibrous tunnel and goes into another tunnel of just fibrous connective tissue of the bands of the flexor carpi ulnaris. So it does no good to keep your momentum and keep going this way looking for the ulnar nerve. It doesn't follow the ulna. It goes right between the two heads of the flexor carpi ulnaris. So as you traverse this turn, it is a dead pivot, 90 degrees going this way. So I was probably following it for the most part. There it is. So medial epicondyle on the left, olecranon on the right, Osborne's ligament looking like a patellar tendon going across the screen horizontally. Let's follow that ulnar nerve distally, 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 and then there it is tucked between the two heads of the flexor carpi ulnaris here. And you can definitely count those fascicles. If I was to pause the image, I could certainly count those fascicles and probably zoom and measure those fascicles very nicely. So it's nice to have this level of frequency, especially when you're dealing with pain generators and you end up with some loose little neuroma or schwannoma or a little neurolema, and you're really just trying to figure out where they originate. Go ahead, Bill.
Hey, Daniel.
Yes, sir.
We've got about 2 or 3 minutes left.
All right.
Try to make sure we allow a little bit of time for the questions.
I think that probably wraps it up, really, is just focusing on that ulnar nerve posteriorly, those little tips and tricks, turning the corner. If anybody does want to type questions into the Q&A portion, not the chat, there's 2 buttons there at the bottom of Zoom. Q&A is the one that we're watching, and we are looking for your questions, and this is live, so any of your questions have to be typed for regulatory reasons. We have no idea what you guys are going to say, so we like to keep these things recorded and somewhat controlled in that manner, verbally speaking, and just things happening in the background and audio to control that. But feel free to type a question, and if you'd like us to cover something really quickly, we can, or answer any questions about what you've seen today as far as equipment or technique.
Daniel?
Yes, Bill?
We have one question here asking for alternate views of the distal bicep tendon. Could you show us a couple alternative ways?
I would be glad to, and anybody that wants to stick around for an extra 2 or so minutes, I'd be happy to show this. Otherwise, the content of the webinar is basically complete. So what we're going to do, after that anterior window, we're going to go medially through what's called the pronator window. So I'm going to focus on the medial epicondyle side of the ultrasound image, where I see the ulnar and the distal humeral edge. And then all I'm going to do is fan my beam. I'm going to bend Jamie's elbow just a little bit. Hopefully I got both cameras looking okay. Good. I'm just going to fan my beam over to the radius. The radius, I can feel it back here. So the intersection of the beam is relatively back here at my fingers. Now, remember, the ulnar branch of the brachial artery is bordering right there, the distal biceps. So now I just need to rotate the transducer, elongate the ulnar branch of the radial brachial artery, and use it as an acoustic window. And there we can see the distal biceps attaching right there on the radial tuberosity through the acoustic window of that ulnar branch of the brachial artery. So that's one view of it right there. And it's a nice one because you can actually pronate and supinate right here. And let's get a bit of a dynamic maneuver of this one that's more short axis. There we go. That's better. And then we can do a kind of a forced pronation, supination this way. So that's the second window, pronator window. Third one is more flexion and lateral, okay? So we're going to come at it across this way, opposite side of the radius. So what I'm going to do now is I'm going to look for that distal tibial elbow joint, a little bit more depth. There goes my gel again. So here's our radius. I need to find out if I'm over the neck approximately. So here's the head superficially. Remember we saw the radial head earlier. Neck. And here comes the tuberosity level. So the tuberosity is on the opposite side. It's way down here. So here's the distal biceps tendon here. But if I have Jamie supinate, we can see the radial tuberosity trying to make itself known more anteriorly. So this is the lateral window, the distal biceps tendon. It's a great dynamic maneuver. So I'm going to have her pronate. And while she's in pronation, I'm going to segue to the posterior window. So when she's in pronation, the radial tuberosity has now moved itself posteriorly and squeezing up between the ulna and the radius. So here I'm going more posterior, 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 and you'll see another little bird's beak has wrapped itself around. Bring our depth up for perspective, and now we have the ulna and the radial tuberosity here. So I'm going to have Jamie supinate and pronate again, and then bringing it forward very nicely there. Just to check our work and make sure we're not losing any defects here, I'm going to go long axis to the radius. And what that's going to do is allow me to visualize the entire footprint of the radial tuberosity and the distal biceps tendon in cross section. So this is the entire footprint right here. And it's very important to look at things in short and long axis. This is the entire footprint of the distal biceps tendon across the radial tuberosity. So that's the posterior window. So thanks for sticking around for that. I was hoping somebody would ask about it. It's really fun to show. We're out of time by 5 minutes. Is there any more questions that are fairly quick? If so, we'll try to make them for the next power hour, likely here in 2 weeks.
One other, Daniel,
Yep.
real quick, if you can.
Sure.
So the posterior interosseous nerve through the supinated funnel full section.
You bet. So radial head, neck, tuberosity level will start to show me where I should expect to see the supinator. Let me flip the probe because that's how the PowerPoint presentation was. So here's the radial nerve, and let's follow that radial nerve. Let's follow it distally, 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 slightly more anteriorly. Now over that radial neck, we start to see pockets of the supinator showing itself right here. So when I start to see the bulk of the supinator show itself, I'm looking at this branch about 3 o'clock on the image, and we're going to watch it follow the fascial plane down to the supinator. Everybody see that right there? Follow, 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 follow. Now we see the supinator. Watch it split into two. So supinator has a deep and a superficial component here. So here's the superficial and the deep, and then we've seen that nerve right there just take up that fascial plane. So right here is the posterior interosseous nerve in the supinator. There we go. So the entrance to that is the arcata feroce. And there's what it would look like in long axis right here. So here it is in long axis, leaving the main radial area where the fascia starts to split into the supinator. This is the arcata feroce right here, this little entrance right there.